All right, let's talk about acute low back pain. I mean, it's got to be one of the top 5 things you're going to see on any given day in clinic, right? So, how do we actually manage it effectively without getting totally lost in all the different options out there? Well, in this explainer, we're going to break down a really clear, evidence-based roadmap, one you can actually put to use. So, here's how we're going to tackle this. First, we'll get a handle on the basics, what we're actually treating. Then, the most important principle, staying active. We'll get into first-line treatments, what to do when you need more firepower, and, just as important, what treatments to avoid. We'll wrap it all up with patient education and what to expect.
Okay, first things first. Let's really get a handle on the scope of this problem and what our goal should be.
Okay, check out this number. Over 85%. That's a huge majority, right? That's how often, in primary care, we can't point to one specific thing and say, aha, that's the cause. It's what we call nonspecific. And you know, that single fact is a total game changer. It means our entire approach shifts. We're not on some big diagnostic hunt for a rare disease. Our job is to manage the patient's symptoms.
So this is what we're talking about, acute, nonspecific low back pain. Let's just break that down. Acute means it's been going on for less than 4 weeks. And nonspecific is the key part. It means we've done our due diligence and ruled out any of the big, scary red flag conditions. You know, things like a fracture or major nerve compression.
And here's the thing, because this is almost always a self-limiting problem, our main goal is actually pretty straightforward. It's all about short-term symptomatic relief. We're just trying to make the patient comfortable and help them get through this episode. We're not curing it, because in most cases, it's going to get better on its own.
All right, so let's get into what is probably the single most important piece of advice you can give your patient. And honestly, it often runs completely counter to what they think they should be doing.
This right here shows the huge shift in thinking that's happened over the years. The old school advice was always go lie down, rest in bed. We now know that's absolutely the wrong thing to do. It can actually lead to more pain and a slower recovery. So what's the new rule? Stay active. The evidence is crystal clear on this. We want to encourage our patients to get back to their daily lives as much as they can tolerate and then gradually increase their activity from there.
So we're telling them to stay active, but what else can we offer to help with the pain? Well, the guidelines are pretty clear that we should start with non-pharmacologic therapies first.
Okay, so what are our non-drug options? Let's be honest. The evidence for a lot of these is, well, it's pretty modest. Superficial heat? Yeah, it can provide a little bit of short-term relief. Spinal manipulation? The data shows some modest improvements. Then you've got massage and acupuncture. The clinical benefit isn't really proven, but hey, some patients really feel they get something out of it. So, at the end of the day, this really comes down to a shared decision. It's a conversation with your patient about what they prefer, what they can afford, and what's available to them.
But what happens when things like heat and staying active just aren't enough? That's when we start thinking about medications. And when we do, it's really important to have a clear, stepwise approach.
And this is basically our roadmap for medications. Step 1, start with an NSAID. Simple. If that's not cutting it, step 2 is to add, and I want to emphasize add, a non-benzodiazepine muscle relaxant. Only if that combination still isn't working do we even begin to consider other options, and we do that with a lot of caution.
Now this is a super important point, a real practice changer. For years, I mean decades, we were all taught to recommend acetaminophen first. But the evidence now, from multiple big reviews, is just undeniable. For acute low back pain, it's no better than a sugar pill. So even though NSAIDs only offer a modest benefit, they are, without a doubt, our first-line choice.
So what does that look like in practice? Well, for the common over-the-counter stuff, you're talking about ibuprofen, say 400 to 600 milligrams 4 times a day. Or naproxen, maybe 250 to 500 milligrams twice a day. The really key thing to tell your patient is that this is a short course. We're talking 2 to 4 weeks max. And as they start feeling better, they should start tapering it down.
All right, so if the NSAIDs just aren't cutting it on their own, that's when we move to step 2, adding a non-benzodiazepine muscle relaxant. They can definitely offer some extra short-term relief, but, and this is a big but, there's a trade-off. These often make people drowsy or dizzy, so you have to be really careful, especially with your older patients.
Okay, so we've talked about what to do. Now let's switch gears and talk about something just as important, what not to do. Let's cover the treatments that are either ineffective or worse, can actually cause harm.
And this brings us to the elephant in the room, right? Probably the highest stakes question we have to answer when dealing with acute pain. What about opioids? And here is the bottom line, and it's backed by some really high-quality evidence. For your acute low back pain, adding an opioid to standard care like an NSAID does nothing. Patients don't get better faster. They don't have less pain. They don't function any better. All you're doing is adding all the massive risks that come with opioids for zero proven benefit. That's why they really shouldn't be part of our routine plan for this.
And that list of things to avoid goes on. I know it can be tempting. You want to give a course of steroids for the inflammation, right? Or maybe a benzodiazepine for those muscle spasms. But the evidence just isn't there to support it for this kind of pain. Same goes for stuff like traction or paraspinal injections. Honestly, sticking to what we know works is the best way to protect our patients from treatments that are, at best, a waste of time and at worst, potentially harmful.
All right, let's get to our final section, and this is so important. We're talking about patient education and setting expectations. And I want you to think of this conversation as a powerful therapeutic intervention in itself.
Look, this might be the most powerful piece of information you can give a patient who's in pain. The prognosis is overwhelmingly good. The vast majority of people, we're talking 70 to 90%, are going to be feeling a whole lot better within about 7 weeks. Just telling them that, you can see the relief on their faces. It calms their anxiety and gives them the confidence they need to, you guessed it, stay active.
But we also have to be realistic with them, and that means talking about recurrence. The reality is, a lot of people, up to 70%, will have this happen again within a year. Setting that expectation up front helps them understand this isn't some new, scary thing. It's often a recurring issue, but it's still a benign one.
And this right here is why that conversation is so vital. When we actually take a few minutes to explain that this is a benign condition and we hammer home that stay active message, it literally reduces how often they feel the need to come back to see us. It's a huge deal. We're not just treating their pain in the moment, we're empowering them to manage it in the long run.
So that leads us to one final, really important question. If we know that these episodes are probably going to happen again, is there anything we could recommend that's actually been shown to help prevent them?
And the answer brings us right back to where we started. It's exercise. Now, to be clear, we're not usually talking about a formal physical therapy referral right in the middle of an acute episode, but encouraging a regular, long-term exercise program, that is the single best intervention we have for preventing recurrences. It just reinforces that core idea. For low back pain, movement is medicine.